I'm Rene Kahn. I'm professor and chair of psychiatry here at the Icahn School of Medicine. I'm going to lead a panel of research experts, and you may have heard them present this morning, and we're going to talk about research aspects and how can research help us in actually achieving those very laudable goals that we just heard in the last 10 minutes. So if I may ask the panel to step up. So we have a panel here of, like I said, 4 and hopefully 5 in a little while experts in the field of research. And what I wanted to do is start out with a single question, and maybe then each panel member can briefly, because most of the audience must have heard you speak this morning, but briefly introduce yourself and maybe in a few sentences the research that you have been doing. But the question I'd like you to address after the brief introduction in a few minutes, what do you think would be the most important piece of research that would actually help reduce violence against children? So what would you advocate and what would you do? So can we start with you, David?
All right, well, I'm going to switch a little bit because I actually think the most important research should probably be program evaluation. But I'm an epidemiologist, so I just want to address the issue of epidemiology, which is so important in dealing with any kind of a major public health issue. And our epidemiology in this area is pretty bad. So I like to say, for example, we know how many cases of Powassan virus there are in the country, but we don't actually know how many kids are sexually abused every year by coaches or by priests or by anybody. The systems are grossly inadequate for our tracking the nature of the problem. And it's in a number of levels. The National Crime Victimization Survey, which is our main source of crime victimization information, doesn't get any information on children under the age of 12. And it doesn't get information on some of the classic kinds of things that kids suffer from, like nonviolent sexual abuse. The police data is terribly inadequate in the sense that currently, right now, they don't collect any information on age of victims. So when you look at the sexual assault data, you can't tell what percentage of those victims of sexual assault are children. The child maltreatment data has a big problem. It's gathered with different definitions in different states, and the big problem is that the stuff that the child protection agencies get is all about maltreatment by caregivers. So you can't put that together with the information from the police and find out what the total number of victims of child molestation is, or what the total number of victims of family violence are. It's a real serious problem. So we need much more regular systems of gathering information on how many children are being subject to violence. I would say there's no reason not to do it on an annual basis. And the other thing that we need that we don't have good information on is much better epidemiological systems to let us know how it is being responded to by the systems that are set up to respond to it. So we don't know, who first finds out about a lot of these exposures, where the reports go to, and how many referrals are made to intervention agencies, how many people receive services, how many kids receive services around these things. It's very hard for us to track our improvement in this area. And a lot of people give priority to the population surveys type of epidemiology, but I think that these agency study surveys are really crucial for making changes in policy to see where the gaps are in terms of service delivery and to make changes to our system. And we're really entirely lacking in that. I'll stop there.
Well, sorry to interrupt my own idea with going one by one, because this is obviously an extremely important issue. But how do you think we could get these numbers? Because clearly these are loaded issues in the sense that people don't want to talk about it and try to hide it.
Well, we now have 40 years of gathering information about these issues from children, from parents, from families, from practitioners. It's not perfect, but I think it's pretty good, actually. And the question is, I don't think the question is methodological. I think the question is simply putting the resources to doing it.
Okay, thank you very much. Bruce.
Well, in terms of research that related to prevention, I think we've already heard examples of interventions such as the nurse-family partnership and the Jean Brodie intervention and things like it, which involve both the parents and the children as a way of reducing violence. I think we already know enough to apply these programs where we can. But at the same time, as a basic researcher, I think we need to know more about sort of underlying mechanisms, both things going on in the brain, but also in the rest of the body because of the multimorbidities that I mentioned in my talk, and the fact that we can't ignore systemic disorders as well as things going on with mental health and neurologic problems. I think the one area which was mentioned but not really discussed in depth is more and better understanding of sex-based differences, because, as I said very briefly, the entire brain is a target of sex hormones, and you have not only the mitochondria from the mother, you also have other factors that add to the sex chromosomes, for example. And I think we're only beginning to understand the widespread nature, even though I think what we also know is that men and women do most of the same things equally well, but they use different strategies and probably different circuits in the brain. And I think we haven't really fully appreciated the implications of this.
Yes, yeah. I do have some follow-up questions, but let's move on. Yeah, so Martin, please.
Okay, so in terms of reducing exposure to childhood violence, a couple of points. First is the importance of asking. When I started doing this research many years ago, we asked a lot of questions of individuals with maltreatment. The IRB was very concerned about what kind of problems that we would stir up in individuals by asking about these individuals. And we asked hundreds of questions online to these individuals, very pointed questions, and they were very concerned. And so we've had a psychiatrist provide 24/7 coverage for people being asked if they had a bad reaction. We've collected this data on over 3,000 individuals, and not a single person is called having had a problem asking or being asked. And that's sort of a change the way the field has gone. Back when I was first training, there was a real concern about asking people about whether they were feeling suicidal. They thought it might implant an idea or something, and it went from being a fear to now being malpractice not to ask. And this should also be in clinical practice malpractice not to ask about exposure. Second important point that I want to make is, and we haven't really talked about this enough so far, is the importance of emotional maltreatment. There's been a lot said about physical maltreatment, sexual maltreatment, and neglect. In terms of risk for psychiatric problems, like mood and anxiety disorders, we find that emotional maltreatment is the most critical risk factor. And that one of the big problems that we have is that when we put together programs to say, don't hit your kids, don't physically abuse your kids, what happens is that parents start emotionally abusing their kids instead. And that the payoff isn't going to be good from that switch. So we need to educate equally as well that saying things like, I wish you were never born and why can't you be as good as your brother, are very toxic. And we need to understand that. I think a point that David made that's really important is that peer victimization is a critically important factor also, and we really need to pay a great deal of attention to that. And I think that there's some good benefits that come from the kind of research that we're doing where we look at the effect of maltreatment on the brain. It's not that if you didn't do the brain research, you know equally well that maltreatment is a horribly bad thing for children. But the fact that you can see brain pictures where you see brain regions change sort of gives that scientific credibility to things that sometimes sways people. And that if you really tell parents that you're affecting the children's brains, you're affecting their intelligence, this is going to have a lifelong impact, that you can really hope to see big changes in behavior over time with appropriate psychoeducation programs like the nurse practitioner model.
All right, thank you very much.
Thank you very much. Yeah, Martin, and then Victor, please, yes. And then welcome, Beatriz, thank you.
So sometimes I get concerned about our nomenclature and our terminology because we are really disseminating a lot of important information, but some people are doing it under the umbrella of ACEs or adverse childhood experiences. Other people use the term toxic stress. Then I come and I talk about PTSD, traumatic stress, and there's many terms out there. And essentially, we are all talking about the same thing or very similar things, which is when bad things happen to children. So I think an important thing in terms of the next step of what needs to happen is that there needs to be an integration. We need to break some of the silos that currently exist. In some ways, that's actually good news, because what it represents also is that many disciplines are meeting at the summit and are recognizing that this is a problem, and we all come with our own terminology, but we are all identifying that when something bad happens to a child that is developing, that has serious consequences. So I think in terms of funding and in terms of research, multidisciplinary centers, both national and international, would be a good way to go, where all of these different disciplines can come to the table together. Also, something that is very important is translation. Translation of what science is doing, both neuroscience and basic science, into the clinical practice. These are two groups that are very much into what they're doing and very busy and have their own language, and sometimes they don't communicate. And the best research really comes from clinical experience. The best research asks questions that are relevant clinically, and the best practice comes from evidence. It's important to do education in both ways. I also want to mention two other things that I think need to be looked at by all these groups. One is, we know very little about the accumulation of stressors throughout development and how that really creates very individual, personalized medicine, if you will, stories that are relevant to treat. Individuals are not diagnoses, but are the personal stories that they carry. And for someone who has sexual abuse at age 3 and then gets raped at age 10 and then goes through a fire, at age 20, might be different than someone who goes through a fire at age 3 and then has sexual abuse later in their life. So we need to identify that a little bit better. We also need to look at the issue of accelerated aging in terms of maltreatment, violence, and mental health. Overall, on average, someone with a mental health condition lives 25 years less than someone with a healthy life. So that's significant. And there are biophysiological reasons for that. There are environmental, social reasons for that. That's an area that also needs a lot of investigation.
Thank you very much. Great. Beatriz, yeah, thank you.
Yes. Hello. So building a little bit on what Victor said about multidisciplinary interactions, that will be critical. So in my field of developmental cognitive neuroscience, we are focusing on, number one, predictors of impaired development, and we think that the next step where there could be substantial support is in correcting trajectories. And again, being able to talk to clinicians, being able to understand what are behavioral therapies that can help correct this trajectory, what are more mechanistic sorts of treatments, and yes, pharmacology as well, but there are other innovative processes that can really come to the fore, all from having apps on people's phones that can not only assess what's occurring from moment to moment, but can actually provide some feedback that will affect how that brain is habituating to a form of operation that can really help. And from earlier talks as well, identifying that those who are resilient to trauma still have the signature of the trauma in their brain. It really speaks to the fact that there are compensatory mechanisms so that one can survive trauma and then actually access compensatory mechanisms that allow them to have a fruitful life. Identifying what those mechanisms are and then building on them so that that can be enhanced, I think would be a very great investment. So I'm really talking about that area of prediction, but importantly, of treatment.
All right, thank you very much, Beatriz. So, not probably by coincidence, we're here at the table from prevention, primary prevention, in the epidemiology, to improving resilience. And if you improve resilience, usually you already have been exposed or will be exposed. So that's the whole gamut. Does anyone want to comment on either how would we be able to prevent it from occurring in the first place, and how would we improve resilience? So who wants to go for that? So how, either you can.
A very important piece of the problem from my point of view is we have a huge number of people in our society right now who are engaged in behavioral interventions in schools, guidance counselors, in mental health agencies, in conjunction with medical practices. I think the big problem is that most of what they're doing is not based on models of evidence-based practice that we know to be successful. And there's a lot of questions about this and a lot of pushback about this, or should we just focus on that sort of stuff? I think, though, we do need to make a big effort to study what actually people are using to work with children and families that are having problems, and how we can move them towards doing the things that we know work best. And there are a lot of obstacles to doing that, unfortunately. There's, just the difficulty of changing the things that you do. There's, the feeling that the evidence-based programs out there aren't really kind of suitable for the kind of practice that I do. There's time constraints and money constraints. There's the fact that a lot of people don't get access to anybody at all. But I think studying the service delivery system and doing lots of experiments and studies about trying to improve the delivery of evidence-based practice is just a foundational thing that we can do in this area to improve both prevention and intervention services for kids and families.
Great. Anyone wants to add to that? Yeah, Victor, yeah.
I think the better we get at identifying predictors of treatment response, the quicker we can get to building resilience. One thing that our field really is way behind is in developing algorithms of care. So many times the treatments get chosen by the expertise of the counselor or therapist or physician rather than by the accumulated literature or the research. So we really need to develop algorithms of care, and we need to identify predictors of treatment response for different treatments.
Beatriz, how about improving resilience? What, I mean, you said some behavioral interventions, but you'd like to be earlier than that, I guess.
Earlier would be best, but as I showed this morning, I think the adolescent period is a real, unique period of opportunity to affect trajectory. A lot of times, what is occurring is that trauma and the effects of trauma are not known until later in life. And I think many people say, well, it's too late. And I think that that is not the case. I think that there are ways, even beyond behavioral interventions, which are ongoing and so forth, really innovative ways. I said brain stimulation. We don't know yet, but it is so promising, and reaching out to other fields, from Parkinson's to Alzheimer's, and seeing what's working for them, I think would be a very innovative way to try to move and take much bigger steps. And other areas that we haven't even thought about yet. So behavioral intervention, yes. Pharmacology, yes. But innovative approaches and to continue even through the adolescent period, I think, is important.
Bruce, yes, please, and then I think Martin, yes.
Physical activity is, of course, important. It's important in Parkinson's. It slows down Parkinson's. It increases neurogenesis. It increases the opportunities for plasticity of different kinds. And, of course, with games and so on, we know the power there, organizing group activities. But physical activity is something that is not usually measured, monitored, And enhancement of it, obviously, we know about it for cardiovascular function, but it's also really important for brain function, as I tried to say in my talk.
Absolutely. Martin, yeah.
I was actually going to echo very much the same. I think in terms of resilience, we really need to do more research. I don't think we have a good fundamental understanding of what leads to resilience. So we were very surprised in our research to find that the brains are altered in individuals who we consider resilient. Their brains aren't protected, but they're compensated in some effective way. I think one thing that Cotton mentioned is, can we enhance resilience by understanding protective factors? And I think we really need to look at protective factors from a developmental perspective in terms of those types of experiences that inoculate you and make you more able to tolerate later types of stressful events, and those kind of experiences that are more rescue factors that will help put you back on the right course if you've experienced something earlier. But there's a lot of confusion and talk about that. Victor mentioned one, the protective factor of having some adult in your life who cares about you. But we found in our data that 96% of our individuals in a community sample have at least one person in their life who cares for you. The absence isn't a protective factor, it's the absence is a risk factor. And I think we really need to understand what are true kinds of relatively unique experiences, not universally shared experiences, that make you more able to tolerate kind of stressors, and that kind of research is desperately needed.
Great. Yeah, Victor, and then Beatrice. Yeah.
If I could make one more technical comment on exercise, because of particular interest for children that experience maltreatment, sometimes increased heart rate, sweating, things that you see in exercise are really cues or triggers of the abuse they experience, so they may tend to avoid it. So it's not only prescribing the exercise, but actually facilitating maybe in an exposure type of way, desensitizing type of system, how they can approach exercise.
All right. That's a very good point. Beatrice, yeah.
So thinking about this opportunity of the adolescent period, what the brain is trying to do is to determine, like I said before, what is going to be its mode of operation. So whatever interventions that occupy the brain in a predominant and consistent fashion can start to change the brain. The brain is really just trying to say, okay, what is it that I'm going to use a lot of? And let me solidify this. If it's trauma, yes, you can have overactivity of the circuitry that has to do with fear, that has to do with depression and so forth. But if alternatively you're exercising the circuitry that supports resilience and control over this pattern, in the long run, the more you use it, the more the brain will want to keep it and make it predominant.
Yeah. So, I'm hearing a lot of abuse, stress, emotional neglect of the brain. And, I've seen your presentations, and many of you mentioned that as an important, one of the important sequelae of that. Now, when does that start? Does it start in utero? Does it start in adolescence? And if so, the earlier it starts, the more important it will be to start early, and maybe even then, although I heard you say that, Beatrice, that adolescence is an important period to intervene. Shouldn't we be earlier? Shouldn't that be during pregnancy when the brain actually is being developed? So Bruce, for instance, how about you?
There are studies that have focused on telomere length as an endpoint of sort of cumulative endpoint of what I refer to as allostatic load,
right,
looking both in the mother and in the offspring. And one of, not surprisingly, with prenatal stress, telomeres are shorter in both the mother and the offspring. One study, however, shows that these differences, this reduction in telomere length, even persists into childhood, which of course is pretty scary when you think about it, but not surprising, I guess, when you think about the other long-term changes. So it's one way of monitoring this, and what it suggests is that there is an altered physiology both in the mother and therefore in the offspring, which can inevitably affect fetal development. and increase, among other things, risk for some of the disorders like schizophrenia, autism, and so on and so forth. So we clearly need to pay attention to that. And then there's increasing evidence that there are epigenetic factors, not just behavioral, that may be transmitted by methylation of cytosine residues in the DNA of the germ cells. And these are increasingly being recognized, albeit not ready for prime time in terms of some of the things we're talking about.
Yeah, well, that's definitely something I wanted to touch upon, the let's say the Michael Meany, the generation upon generation. But how about the others? One of you, shouldn't we pay more attention during pregnancy? Because many of these families will, the mothers will have a complicated pregnancy emotionally or physically. And then
one of the most puzzling things is are the effects that, for example, Rachel Yehuda studied of the children of Holocaust survivors.
Exactly.
And apparently some evidence also for children of 9/11 survivors. So there's something, whether it's behavioral or something more biological in terms of the germ cell DNA, or something else, we don't know yet. But it's there and it can't be ignored.
Well, that was my second point, but now you've mentioned it twice, so I'll address it now. I mean, maybe that's where the 7 trillion is coming from. This is not a one generational problem. This is actually from one generation to the other, and this may be until whatever the 7th generation, whatever it is. But so, I mean, this is a huge problem, not just for the one who is abused, but for the other generations that are following that. So, what's your comment? The comment of the panel on this issue, that we're not dealing with a problem for just the person who is abused, but for their offspring as well. That this is, an enduring problem. And how can we address that? And would intervention in adolescents actually help that?
That's a challenging question, because it's really trying to predict the future. But you're right, I mean, there are some elements that are known, right? That you know that the mother has already gone through trauma, maybe through pregnancy. There are approaches, there's fetal imaging that can look at network connectivity, like Martin has mentioned in the past, and you can start to track that. Again, you would have to be following them longitudinally to see and to really understand what are the processes that are going awry. And then maybe have some more specialized approaches that are personal to that individual to try to correct that particular process. But there are going to be commonalities. So there's a lot of work that could be done there. And I feel like, at least maybe others know more, but I feel like this is very early in trying to understand that. But it's good to be keeping.
Sometimes.
Okay, Victor, and then Bruce.
Yeah, sometimes we've treated children that manifest all of the symptoms of PTSD, and we cannot find the trauma. We cannot find any history of trauma. And as soon as we start working with the parent, the trauma shows up. So it's not an answer, but just to add to your question, it could be behavioral, it could be biological, it certainly could be both. Sometimes also what you see, though, is that a parent that has a history of a lot of trauma may tend to go to the other end and overprotect children. And children that are overprotected on the good type of stress that Bruce was telling us about, that's not a good idea either, because then when they're not, they're not immunized, right? So when they really have to confront the situations of life and go to work and all of that, they're not prepared.
Yeah, Bruce.
There's a dilemma from the standpoint of social change, because, and the example of, say, the obesity epidemic, if we assume that simply by diet and exercise we can cure the epidemic, we're totally wrong, because there are these preconception, prenatal, postnatal, through the life course issues that are all worth addressing. And we need to address all of them. But if we expect change to occur immediately because of the long-term effects, it's not going to happen. It's taken decades for this obesity epidemic to build up. And even if we did something right now at all these levels, it would take decades for it to dissipate.
Right.
So we have to be patient, and we have to make people realize that all of these things are worthwhile pursuing, but they're not going to solve the problem all by themselves.
Absolutely. Yeah, David, you are going to comment, but I also had a question for you. So is there enough focus on the transgenerational effects of abuse? I mean, is that part of the research agenda? And if not, shouldn't it be? But that you had a comment yourself, so go ahead.
Probably is not. And I'm sitting with a panel of basic researchers who I think are doing fabulous work, but I'm very focused, I'm getting old, I'm very focused on applied stuff that I think can produce important changes in the short term. And so seeing where the leverage points are seems very important to me. And while we're waiting for the basic research to pay off, I just want to point out some of the other places where I think there's really tremendous benefits that we could realize in the short term. If you look at the places where, in our society, where the most money is being spent on violence prevention and response, it's in the child protective system, and it's in the law enforcement system. And these are both institutions that do not have a very long history of, or very little history of empirical research about their practice, and are somewhat resistant to the kind of scrutiny and the kind of evaluation that I think is really needed to improve practice in this area. I think a very important priority for research is to take the activities that are going on in those institutions and the large amounts of money that are being spent, and to see how it can be refigured and repurposed and reorganized, and in some ways to make the practices more efficient, more effective, more directed towards this aspect of the problem, usually using a lot of things that we now know from, I think, considerable amount of experience and research about what works. And so some of you who are either part of those organizations or who have relationships with them but who have a research background, I really urge you to build alliances with the child protection systems and the law enforcement to see if you can bring some of your research training, your critical thinking skills, and some of your knowledge about evidence practice into those arenas, because I think there's tremendous benefits that can accrue to increasing that orientation in those institutions.
Yeah, thanks. And that's, I think, Victor, what you've been saying. I mean, there's too many silos. And frankly, if, in my own practice, I mean, it's psychiatrists, psychologists, maybe social workers. That's about it. But it doesn't go broader than that. You need policing, you need judicial system, and you need. So how are we going to get that? Because it's not happening. I mean, it's still very much a siloed system, where you have the medical profession and the psychologists and psychiatry, and that's about it. But we talked about, pediatrics, you talk about OBGYN, during pregnancy. I mean, there's no communication, I think, between those, is there? I mean, Victor, I mean, you brought it up.
Just centers nowadays, they don't need to be limited by space. They really can occur virtually with technology and international, and I think we need to put more resources into that.
Okay.
How many people are here from law enforcement? I'm kind of curious.
Is there anyone? Did you see an arm?
They're coming tomorrow. They're presenting probation, criminal justice, the judges, the lawyers.
Well, this is maybe a very good moment to open it up to the public. I think you gave the signal. Thank you very much, David, for that. So are there questions and comments? Because I'm sure, there are very different ways to discuss this issue. So please go ahead. If you just introduce yourself and
I'm Doug Wade. I'm medical director of Children's Village, and I'm a pediatrician.
Okay.
So what strikes me in just between the discussion this morning and here is our focus that these are people who are abnormal. And working with these kids, I'm struck at how resilient they are, and that we're really looking at bell curves when we talk about cortisol levels and we talk about people's responses to stress. And I like to focus on PTSD as being a normal reaction to an abnormal situation. And what if we keep talking about resilience? And really what we're talking about is we're looking at people who are resilient, and their stress responses are actually a sign of the resilient. Their PTSD symptoms are a sign of the resilience. In fact, it's proof of what happened to them. In many cases, we don't know, like you said, we don't get a history of trauma, but you have a kid coming in and they're dissociating and they're getting into fights and they're running away and they're getting sexually victimized. And you pretty much know something bad happened there. But if I teach them that their symptoms are a sign, proof that something bad happened to them, we can begin working on that. And the last thing I'd say is I'm struck working in child welfare how many people I work with themselves had histories of abuse. And a lot of the kids I work with want to go into these professions. I think there's a lot to be said for people finding a cure through working with people, and that itself is a healing process and a way of reworking their trauma.
Yeah, that's a great remark. Yeah, you can applaud. Yeah, who wants to react? Bruce? Yeah?
It just reminds me of a colleague, Robert Whitaker, who at Temple, who's also a pediatrician, has been studying Head Start teachers in Pennsylvania, and has discovered that a trait of constitutional mindfulness, that is, being able to not ruminate about things that you can't change, is a feature of better health, self-reported health, independent of a history of their own life history, and they're better teachers.
Yeah.
Now, whether one can teach these kind of things is, of course, the huge question.
Yeah. Anyone else from the panel want to react to this?
No, I agree completely, and a lot of people use the term post-traumatic stress injury because they don't consider PTSD a real disorder, meaning that if any of us went through torture, for example, the prevalence rate there of the symptoms is about 99.9%. So it's almost like a normal, natural reaction to when your physical integrity or your life is at risk. And what's missing a lot is for children to understand that, to understand education, to learn about classical conditioning. Because the message that they get is that they're a problem, or that they're crazy, or that they're bad. And that happens at a very sensitive period in their life, when they're creating a sense of identity. So they internalize those messages and they say, well, if I'm crazy or if I'm bad, I must behave appropriately. But a lot of education into that post-traumatic stress injury that we're all susceptible to can really create change.
Yeah.
David.
I want to make a comment, a little challenge my colleagues here a little bit, because I'm very excited about the brain research, but I am concerned that on this issue of what survivors are going to think is that if they begin to have a conceptualization that they have damaged brains and other people think about them as having damaged brains, there may be negative consequences that occur as a result of that formulation. So I think it's very important as we roll out the brain research, and I don't know that this is always being done, because when I hear many of my non-brain research colleagues use it, it oftentimes is meant to mobilize people to do something about the problem, to say, this is a serious look, it affects the brain, but without putting the caveat in, yes, but if it's treated, we can reverse those things, or we can overcome those things. And that's a very important distinction, I think.
Yeah.
Martin. Yeah.
In response to your
I
question,
won't forget you guys. I won't forget you.
And to the previous one. So the way that we're looking at it is the brain is modified, and we don't use the word damaged. That it's phenotypically modified and adapted based on the experiences that it's had, and that those experiences are probably modifying it in a way for it to better survive and reproduce. So that what you're talking about, the last person asking the question, we're talking about individuals whose brain is phenotypically modified. I don't necessarily refer to them as resilient. I refer to them as modified, because some of them have been modified, but they're not able to concentrate in school, they're abusing drugs, they're thinking about suicide, and they're not doing very well on any level of function. And other ones have had similar experience, and they're doing quite well. And I do make a distinction between those who aren't doing well and have modifications and those who are doing well and have modifications. So we need to keep that in mind. But I think it's really important not to point out that this is damage, that they're modifications, and they're adaptive modifications. And that, when you tell this to an individual clinically, it has a huge effect. That it is actually incredibly therapeutic to say that you've been modified in a particular way and that what you've been doing makes sense and we can explain it and that you can then make progress in moving on from there. I'm not sure how much it's reversible, but I think it's something that you can respond to, adapt to, and improve from.
Essentially, what post-traumatic stress injury, I'm going to use that term now, tells us is that environment has an influence in the brain. So if you take the bad or the damage or everything away, so good environment in these neuroplastic regions should really have a good effect. So when you do a therapy that works, a social program that works, it's working because it's creating biological and social changes in the individual.
Bruce, briefly, yes.
And remembering that it is not damage, it is plasticity. One of the key elements, if the brain gets stuck and then things change,
Right.
there is compensatory plasticity. It may not be, it probably isn't reversibility. I tried to emphasize that. It's compensatory change. It may not even be the same brain region. It may be some of the things that Dr. Teicher talked about that's actually compensating in a way that counterbalances something
Right.
and allows the brain to function more normally.
Yeah. I'd like to give you an opportunity to ask. Yes, please go ahead.
Thank you so much. My name is Dr. Brooke Pal Chan. I'm a pediatrician. I previously worked with Dr. Doug Waite at the Children's Village for about 6 years in the foster care clinic. I currently am the medical director of the New Rochelle City School District up in Westchester. I also have an ACE score of 7 from my childhood. A lot of what I hear from these meetings, do I have a modified brain or not? I think, working in a climate where I've been able to empower others, find the voice for others, has permitted me to excel within my career. The work that I did with the children in foster care, identifying those at risk for sex trafficking and others, I saw those young adolescents turn into adults with great futures ahead of them. Having that consistent adult model is fabulous. What are we doing in the schools? I wish you had been at my board meeting on Tuesday when I presented our health services department, how we've been breaking through the silos in our school district. I work with the student services, with the Department of Guidance. I work with pupil support, where we have the psychologists and social workers, and the special ed department. I think we need more pediatricians staffed in our school districts. New York City is a big conglomerate. I'm in Westchester. There's a big diverse representation of how physicians interact on a regular basis with our schools. I happen to be employed by the Board of Education, so I work throughout the entire school year full-time for this school, and I think it makes me become a critical advocate for youth that attend our districts. This is where we can see those behavioral problems, we can participate in those meetings, we can make sure we're not doing redundant work in our fields, and this is a great opportunity to, it's budget season, go listen to what's going on in the school districts, because that's where the kids are. And the kids that are not there need to be there, so they need to make investments in the attendance, truancy type officers, because we don't know where they're going, or we know where they're going, and we really don't want them going there.
Thank you so much. Great. Yes, please, go ahead. That's going to be the last question.
Hi, my name is Maya Handwork. I'm a social worker with the Children's Law Center in Brooklyn. So I was happy to hear, that the idea about, transgenerational trauma was brought up, and, the Holocaust and 9/11 were referenced. And, I'm just wondering in terms of not just the Black experience, but because there's a lot of Latinos that are also come from a history of slavery, whether that's something that's, sort of being considered in the scenario when you don't have the longitudinal studies to, sort of assess this type of, particularly in terms of violence. How is your work, sort of, factoring that in?
Yeah, that's a very, very good question. Who wants to address that? Because that's much longer standing history than the Holocaust and then 9/11. That goes on for generations. That's a very good point. Has any studies been done on that?
I'll just say, I haven't done research in the area, but I'll just say that historical trauma does exist, and not only that, it gets exacerbated by not historical but current trauma that may be happening. So then you have, once again, that accumulation of stressors. And, you know, are there biological correlates to that, to historical trauma? I don't know of anyone doing that type of work.
That's a very good point. All right. Well, thank you very much to the panel. You have been great and very interactive, and thank the audience for their interactions, and good luck.